everyone. I thought what we would do in this video is talk about the different types of action potential. And although previously we've classified the different types of cells as pacemaker cells, conducting cells, and contracting cells, for the purpose of understanding action potential, we're going to simplify it even further, and we're going to classify the action potential as pacemaker action potential and non-pacemaker action potential. And the reason for that is that the differences in action potential for the contracting cells versus the conducting cells are not that significant, and they follow the same general scheme. So it'll be much simpler if we just consider them as essentially one or the other. So I thought we would start with the pacemaker action potential, and we're just going to draw it first, and we're going to draw it on a graph. So I mentioned previously with the nervous system that we didn't have to draw the nervous system one on the graph, but in order to really appreciate all aspects of cardiac action potential, we do have to draw these on graphs, so we're going to do just that. So we'll make the y-axis the membrane potential in millivolts, and we'll make the x-axis time, and we can label it as seconds, or maybe even more appropriately, it could be milliseconds, because this stuff is happening extremely quickly. And we're just going to draw in our threshold at minus 40 millivolts. So it's important to note that although when discussing the neurons, we said that the resting potential was minus 70, and our we had specific values for threshold as well as what the maximum potential would be and what the lowest hyperpolarized potential might be. The values are going to be completely different for the different types of cardiac cells, and they're not even going to be the same within the different categories. So for pacemakers cells, the threshold is minus 40 millivolts, and our lowest potential that we'll see is probably around minus 65 millivolts. So this is what our pacemaker action potential looks like, and we can label it with the different phases: phase 4, phase 0, and phase 3. And the phases are very specific, so you have to learn that phase 4 means something, 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 and that phase 0 means, and it actually is the official name for it. And so when we talk about different drug mechanisms and things, we'll find that it'll affect phase 4 of the pacemaker action potential, or phase 0 of the pacemaker action potential, or that sort of thing. So phase 4 refers to the time period when we have hyperpolarization activated sodium channels opening. So one thing that's very interesting about the pacemaker action potential is, unlike for example, the neuron, or unlike what we'll see in a moment, the ventricular action potential, there is no resting phase. There's no resting potential for pacemaker cells. And that's really critical. The absence of resting potential is what allows for them to have spontaneous depolarization and not require neural stimulation in order to function. And so since there is no resting potential, what happens is, as the cell becomes hyperpolarized, there are special channels that become activated that will open, voltage-gated channels that open because of the hyperpolarization. So we talked before about different types of voltage channels that would open, for example, because the membrane became a certain amount depolarized. And so in this case, instead, these voltage-gated sodium channels are opening because the membrane potential becomes a certain amount hyperpolarized. So the hyperpolarization leads to sodium channel opening and slow sodium entry. And it's going to be very important as we talk about the different types of cardiac action potential to remember the cases where the ions are entering slowly and the cases where the ions are entering rapidly. So slow sodium entry is going to occur until we get to the threshold potential of about minus 40 millivolts. And then from there, we will initiate phase 0, which is basically when calcium channels open. There are two different types of calcium channels, T-type and L-type calcium channels, that are found that allow for phase 0 to occur. For now, it'll be useful to just remember that there are calcium channels opening, but it's interesting to note that, for example, the different types of calcium channel blockers, such as diltiazem, affect only the L-type calcium channel. So it's not it's a little important, but it's not going to be super important for the majority of our physiology discussion. Now, the opening of the calcium channels causes rapid calcium entry and is basically the primary depolarization of the pacemaker cells. And so depolarization occurs until the voltage becomes quite positive, and then from there, the calcium channels will close and the potassium channels will open, and that will initiate phase 3. So phase 3 is repolarization as a result of slow potassium exit. So potassium is leaving, and there are tons and tons of different types of potassium channels actually with different potassium currents associated with them. But for now, we'll just talk about it sort of generically as the potassium is leaving. And so repolarization will occur again to about minus 65 millivolts, and that will bring us back to the beginning. So once we get to minus 65 millivolts, we're hyperpolarized, and we will then begin opening sodium channels again. Now, one thing I want to mention is that, we drew this graph sort of as a generic, but we could say that it was an SA nodal cell that we're talking about. And I just want to compare an SA nodal cell to an AV nodal cell. And so basically, if we draw the AV nodal cell, it will have its pacemaker action potential will have the same features of the SA nodal cell. The primary difference between them is that the pacemaker potential, which is the time period when the sodium channels are opening and slowly allowing sodium to enter to reach threshold, that the slope of that line in the AV nodal cell is going to be much flatter. And so because the slope is flatter, over the course of the time passing, it will take longer to reach threshold. So therefore, it will be a longer period of time before that AV node can depolarize. And so that really explains why it has a slower inherent pacing rate. So all pacemaker cells have the ability to continuously depolarize and keep this sort of cycle going. But the reason why the SA nodal cell gets to be in charge is because it has the fastest inherent pacing rate. And there's an important concept called overdrive suppression that is very closely related to the differences in the inherent pacing rates of the different ectopic pacemakers as well as the SA and AV nodal cells. And we'll actually talk more about that in a separate video so that we can give it ample consideration. But for the moment, it's just useful to compare the differences and see that the pacemaker action potential is really it's very similar when we compare the different types. It looks a little bit different, but it's similar among the different pacemaker cells. Now, most importantly, we need to compare the pacemaker action potential to a non-pacemaker action potential. And so we'll use the ventricular action potential as our model for considering the non-pacemaker action potential. And I think it's important to note that, for example, ventricular cells have a resting potential of about minus 90 millivolts, and atrial cells have a resting potential between minus 80 and minus 85 millivolts. So there's going to be some differences among all of the cells that fall under the conducting and contracting categories, but and the action potential will look slightly different on the graph. But again, the phases are the same. The points that they have to reach are the same, and there'll be enough similarities that this one model will be adequate to consider all of the action potentials. And in the same way as the pacemaker action potential, the non-pacemaker action potential has phases that are specifically named, and the phases are associated with different things that might occur inside of the cells. And what we care most about is when we talk about drug mechanisms, how they affect a specific phase of the action potential. So again, we'll draw our graph and see that we have membrane potential on the y-axis and time on the x-axis. And the same thing is true, millivolts and time in seconds or milliseconds. And then we'll just draw in a couple of important values. So our threshold for these cells is, for the ventricular cells is minus 65 millivolts. The resting potential, as we said, is minus 90. And then a couple of other points we want to hit is the 0 millivolts and plus 30 millivolts. So we'll start with phase 4, and phase 4 is resting potential at minus 90. And so the cell's not really doing anything at that point in terms of having any massive flow of ions. There may be, normal flow in and out, but there's no special currents that are occurring. And so what happens is, and one thing that I really want to make sure, and this is a really critical point, is that unlike the pacemaker cells that just depolarize themselves because they don't ever rest, the non-pacemaker cells need some type of stimulus in order to cause them to become depolarized. And so basically we mentioned a bunch of times the presence of gap junctions, and so all these cells are going to be connected to each other by gap junctions. And so what would happen is a pacemaker cell would depolarize, and then it has gap junctions to connect it to another cell, and when that cell is a conducting cell or a contracting cell, then that cell is going to receive that positive charge that has entered that cell from in those cases it would have been primarily the calcium ions that have come in, but that positive charge is going to flow between the cells, and that depolarization is going to basically bring this to threshold. And so once the cell reaches threshold, it will allow for opening of sodium fast channels and rapid influx of sodium. And so phase 0 is marked by the rapid influx of sodium, and we'll have sodium flow in till about plus 30 millivolts or so. Once we reach plus 30 millivolts, the sodium channels are going to close. And in the same way that we talked about the different types of voltage gated channels for neurons, it's important to remember that voltage gated channels are open and then they close based upon a specific membrane voltage, not because the ions have reached equilibrium potential. They move because they're seeking to reach equilibrium, but the channels are only open for a distinct period of time based upon the membrane voltage. So the sodium channels will close at plus 30 millivolts. And we'll begin phase 1, which is opening of potassium channels and rapid repolarization based on potassium outflow till about 0 millivolts. Now, at 0 millivolts, we reach the plateau phase, phase 2. And so at this point, calcium channels open, and calcium is going to flow in, and at the same time, potassium is going to continue to flow out. So the potassium channels are still open, and the potassium is still flowing out. But because we have an exchange of positive ions occurring, so positive ions of calcium flowing in and positive ions of potassium flowing out in the appropriate ratio, we don't have any actual change in the membrane potential. It's just sort of a net zero movement. And so there's essentially a plateau or a flat component of the action potential where we maintain at 0 millivolts for a period of time. Now, it's very important to note that during the plateau phase, the calcium is entering and muscle contraction is occurring. And we have to consider muscle contraction separately because there's a lot of physiology to discuss, but the whole purpose of calcium coming in during this phase is to allow for muscle contraction to occur, and it's very intimately involved in the muscle contraction process. Now, once muscle contraction is essentially completed, the calcium is going to be taken away, and there's a couple of different methods by which calcium is removed, and we'll discuss those with the muscle contraction physiology. And so then we have simply main repolarization, and potassium continues to flow out until we get back to resting potential. And back to resting at minus 90 millivolts basically brings us back to phase 4, and we are again in phase 4 until the next depolarization occurs in a pacemaker cell that ultimately is conducted via gap junctions to one of these cells, a non-pacemaker cell, in order to then stimulate this process to occur again. Now, of course, the other thing we cannot forget to mention is refractory period. So the time from the initial opening of sodium channels until somewhere in the during the time of main repolarization phase 3, the cells are in the effective refractory period, or ERP. And the effective refractory period in cardiac cells is basically the same thing as saying the absolute refractory period if we were talking about neurons. So they use a different terminology for it. It's still about minus 50 or 55 millivolts that it actually is in the effective refractory period. And then once we get past that, we reach the relative refractory period. And the relative refractory period, if you remember, is a point in time where it's possible to stimulate the cell, but you have to work a little bit harder than usual in order to get that stimulation to occur. And so this basically lasts until we get back to minus 90 millivolts, and then we're just back to resting, and the cell can again be depolarized as normal. All right, so that concludes our discussion on the different types of cardiac action potentials, and next time we'll talk specifically about the physiology of muscle contraction. Thanks for watching.